So Dr. Azola, thank you so much for joining us again this afternoon, and the floor is all yours.
Thank you so much for inviting me to discuss this very important topic of the patient-physician relationship. I have nothing to disclose. We can go to the next slide. And I just wanted to start the talk by highlighting what, to me, defines a relationship. And the relationship is built by three entities. There's the person, right? Could be the patient, the other, which could be the physician, and the relationship itself is the third entity. So it is something that it's influenced by both parties, and there needs to be an agreement and flow of communication between patient and physician in order to have a relationship that will bring reward to both parties, right? And would help and work together in agreement. Next slide. Unfortunately, next slide. There's many barriers, as was pretty evident by our polls, that there's significant issues in this relationship, especially when it comes to chronic illnesses and illnesses that are poorly understood, like the barriers to effective communication that have been studied include actual evidence of deterioration of the doctor's communication skills. Years of medical training actually have evidence of suppressing doctors' empathy, and that it actually can result in derison of patients. So we understand that that is an active process happening within the system of our medical training at this time. Also, doctors are human, and dealing with emotions is complex, and there's a lot of kind of mechanisms of dealing with those complex emotions by going to avoidance, to avoid that that actual experience of those emotions, and simply by suppressing and avoiding engaging in that, and that affects the relationship itself as well. There's also been a growing trend of discouragement of the collaboration, meaning that the doctor discourages the collaboration from the patient. Patient may be asking questions about why certain tests are being done, or to understand what the doctor is recommending, or what the expected outcomes are for that patient. And the physicians, by and large, suppress that. They discourage that collaboration. And there's a perception that patients are passive recipients. But this is certainly the main issues that affect that communication. And like I said at the beginning, we have a relationship that's built with the flow of communication between both parties. So the perception that patients are passive recipients of this information just really disturbs that grounds to create an agreement and a relationship between the two parties. Next slide. And not to mention the elephant in the room, our historic reference of how populations with chronic illness like ME/CFS or other fatiguing illnesses after infectious process have been treated. I'm not going to go deep into this, but I just want to acknowledge that we're aware of the elephant in the room. Next slide. So what are the strategies for improvement on this communication? For physicians, the ACGME has incorporated communication skill training as part of the requirements of medical training in an attempt to make a step on the right direction. The idea of collaborative communication, viewing the patient as an active participant in the treatment plan, And I think that's something that for my specialty of physical medicine and rehabilitation is particularly honed in our training. We usually like to describe the patient as the captain of the team. You know, we're just kind of members of that team, and the captain makes those decisions. And we need to understand what is important to the patient in order for us to come up with a comprehensive plan. Conflict management, like any relationship between two humans, there's going to be conflict. And it's important for physicians to have the tools to understand how to manage conflict with a patient in a healthy way. Also taking time to understand the health beliefs and the values of the patient so that we can better serve them, achieve their goals. Next slide. And I just, another issue is that interpersonal trust, which needs to be built between the physician and the patient. It can be interpersonal or interinstitutional, right? So it's a complex trust system, but in order for physicians to establish the trust in that relationship, it's important that we build the relationship as we know that a healthy trust relationship between patient and physician definitely leads to better medical outcomes and better quality of life of patients. Patient trust between the patients and physicians correlate a lot with the patient's perception of the ability to communicate of the physician, the level of interpersonal treatment, engagement of that patient in the treatment plan, and patient's perception of the knowledge of the patient, which I thought was really interesting, and I have seen that a lot. So engaging with a new encounter, with a consultation with a patient, you know, taking a look at those records, getting some highlights of what has been happening, and coming in with some basic knowledge about what has transpired in the patient's history. It's important, and it's very valued by the patients, and it builds trust. The way a doctor communicates with his or her patient is as important as the information he or she is conveying to the patient. So you can have really deep understanding of a physical process, but the way that the doctor is able to communicate that with the patient, it's what's really key in terms of getting the information received in that exchange between the two parties. Next slide. And this other part of my talk, I'm going to spend a little bit of time talking about what is a medical visit structure, kind of the basics of how physicians are trained to assess a patient in order to obtain the information that's needed, in order to check for positive, pertinent, negative information of the patient history and symptoms. And that really helps us build an understanding and inform how we can create an assessment and plan to put in place. Next slide. So we start with the history of present illness. And the goal is really to get as much information as possible on the current issue that the patient is presenting for evaluation. But we're really trying to also get that information in an organized way, in a methodical way. What's essential, and it's been extremely helpful, it's patients that come in with a chronological outline of the events that have transpired throughout their illness or throughout their lives in a summarized way. just to highlight the main points so we can keep that thread of the story, right? The main threads of the story of what's been happening. It's also really helpful for patients to have organized medical records. Unfortunately, due to the way our medical system operates, compared to other places in Europe where they have shared electronic medical records, in the US, we do not have a common electronic medical record. So our access to evaluations and testing performed at different institutions are not available for us to see. So in the cases where it is, it's extremely helpful. And when it's not, it can be a real challenge in order for us to fully understand what has happened. For example, with imaging, it can be quite tricky because imaging can be read with different eyes. So for example, a CT scan or an MRI has a lot of information that to one radiologist who's not a neuroradiologist specialized in recognizing certain areas or certain subtle changes may not be able to see. So it's important that if you have the studies done in an institution, get the CD copy or at least a way to access the electronic images themselves. So getting the read of the imaging is not very helpful at all. We like to actually see the images and sometimes have different radiologists do a second consult to give us insight into what they can pick up from those images, which may be different than a different radiologist is trained to see. Next slide. Also, I find really helpful that patients describe their symptoms in their own words. A lot of patients that have been sick for a while, have had to advocate for themselves, have had to immerse themselves into the vocabulary of the medical field, and that's valuable. But at the time, at least for myself, at the time that I'm getting to know the patient, I want to know what their body is experiencing. So I want to know exactly what they're feeling and what their sensations are, what is the voice of their bodies telling them. It can really help me guide without having preconceived notions or kind of jumping or understanding. Some people may have a different definition for a diagnosis, and in terms of chronic illness, that can become an issue. So you want to have beginner eyes as a physician, and you want to get that patient experience not metabolized, but raw. We want to know the current functional status, like what is limiting your mobility, your ability to do activities of daily living, what type of activities do you require assistance with, and get a sense of where the limitations are, so that we can then look into these and find ways where you can regain some autonomy, regain some ability to be more independent. And that the field of physical medicine and rehabilitation, it's specialized in just understanding the functional status and understanding how we can make things that may give you some independence, may give you some autonomy, and they don't have to be done exactly the way that they were done before, but we can find creative ways to achieve that independence. And something that's really important in that first meeting is there's a lot of information. There's a lot of complaints and things that you're experiencing, right? Try to highlight what are the top three. What are those top three? And those may change through time, and they will change through time. I call it the whack-a-mole. new symptoms get better, other symptoms get worse. But really kind of keeping the visit with kind of what are the 3 things that are most getting in the way of me living my life, right? That can be really helpful if you can think of that, because that gives the physician then a point of view of what's important to the patient and what we need to prioritize when it comes to creating a plan. Next slide. Then we do a review of systems. And in the review of system, it's a portion where we kind of go head to toe, checking different symptoms of different areas or systems in the body. It's a lot that we need to get through in order to get kind of that section of our assessment. And I just want to mention, like, I feel personally, I experienced that I sometimes seem to be cutting off the patient, and I try to be as sensitive as possible, but it sometimes comes off as cutting off. But we're just really trying to get through a systematic assessment. So sometimes we have to redirect the conversation. We want to get to know all the details, but there's a little bit of a balance of really trying to get a head to toe understanding of the most critical issues. We also want to know what you're experiencing, and I talked a little bit on that already. We don't want to say, or I when patients tell me, oh, I have tinnitus, I stop them and I ask them exactly, what are you experiencing? What is this tinnitus? Is it a ringing? Is it a thumping? Is it a pulsatile sound? What is it that you're experiencing? And that's kind of the information we want to get at. Or saying I have migraines. What are your migraines? Like, where are they located? What is, when do they get better or worse? So it's more like we want to learn about what are the specifics of it, and not what your perceived notion of a specific diagnosis is. It may not speak the same to a different physician than it does to you. Next slide. In terms of medical history, the current medication list is important. Knowing specifically what dose you're on and how long you've been taking those doses. Also, extremely important and helpful for physicians is to keep a list of medications that you have tried in the past but are not currently taking. And we want to know which medication it was, what specific dose it was, what side effects were the ones experienced that led to stopping the medication, how long did you trial it? We want to know those details because we want to know if the medication was tried at an optimal dose, or perhaps it was stopped due to a side effect that may have been caused by a different medication. So it's just important for us to get a sense of what exactly were those medications that you've had in the past and how they kind of were dropped off your list. Next slide. In terms of past medical and surgical history, again, super helpful to keep a running list of past medical history, including pediatric issues. Keep a list of surgical procedures and other interventions and complications associated to those procedures. Next slide. Next slide. Yeah. Past family. Oh, you can go back. Perfect. Past family, social, and functional history. It's very useful to have a clarity on your family history. There's a lot of hints and clues that we can find on family history that can change the course of our workup or allow us to or raise a red flag for something that needs to be ruled out or that we need to think about. So those things are really useful if you can, before coming in, kind of have time to talk about that with your family and have clarity on what those family medical issues are. We want to get to know your environment. We want to get to know where you live, what your house looks like, who lives with you, what your day looks like, what do you do for work. The doctor needs to know that in order to understand the context of where you are, right? We're trying to understand not only the patient and their symptoms that they're experiencing, but how that matches in the context of the environment the patient is living in. And that's also going to be helpful for us to provide input into how to make that environment work better. Next slide. Assessment and plan. The providers may not be able to create a comprehensive plan at the end of your first visit. And I'm just putting this out, that statement out, because it's a lot of information when you have been suffering for a long time and you have been seeing multiple specialists and given a number of diagnoses. And it takes some time to process that information. So it's important for you to understand that at the end of the visit, we're not going to be able to say these are exactly the next steps that we need. We try to come up with a comprehensive, or at least some direction for next steps, but it's going to take time in order for the physician to be able to develop a comprehensive plan. And like I mentioned earlier, a lot of the symptoms fluctuate in intensity, fluctuate in severity, and through time. So it's not, we're not going to have the magic answer at the end of that first visit. It's very important that the patient expresses what are their priorities. And I kind of mentioned this before, but I want to highlight that, in the plan, it is important that you convey, these are the things that are most important to me right now, and how can we proceed forward. And there's been occasions where the physician or myself have different priorities. So it is important to have that conversation, because like I mentioned before, a lot of physicians, or historically, the physicians tend to think that there's a one-way communication, and that can disrupt that relationship, right? When the physician just states what's important to them, it's important for the patient to then also report what is the most important thing in their health priorities, and then come to an agreement in terms of the plan. And ask your provider. I mean, this is why are you recommending a skin biopsy? Why are you recommending a tilt table test? Or what is this gonna bring to me? And sometimes, I explain to the patient why that is important, and they may decide that at this moment that's not important to them, and then we hold off on doing a particular test and prioritize something else. So it is an important conversation to ask why the physician is proposing certain steps in the plan. Next slide. Your doctor, after the visit, your doctor needs and wants to know if you had stopped a medication due to a side effect. So if the doctor prescribes you a medication and you're not sure that you want to take it, or you decided that you don't want to take it anymore, it's important that you notify the physician. It's different for each institution, but we have a pretty accessible system where patients can send electronic messages through our electronic medical record. It's really important that that communication is there. Also, if you see another provider that has a conflicting recommendation and you opt for changing the medication per the recommendations of the other provider, we're not going to be offended. We need to know. Like, it's not going to make the physician mad. We want to know because, you know, we're invested in this relationship and we're making recommendations and we want to know where you are. And, you know, just knowing can become really helpful and can create more of an agreement in the relationship. If you have an exacerbation of symptoms that's setting you back, or sometimes a medication can cause an exacerbation of symptoms, it didn't work out for you. We want to know. I find sometimes patients feel like guilty or they don't want to come. I don't know what the patient is thinking, but sometimes they won't communicate that information. And we really are here to help the patient. And you know, sometimes we're making recommendations best guided by our best understanding and knowledge, but that's not perfect. And by any means, everybody reacts different to different medications. So it's important for us to know what happened and we like it better when the patient tells us right away. Next slide. So what are the ways that a patient can help a physician that's trying to, or that you're engaged in a relationship with to manage chronic illness? I think facilitating communication between providers has been something that has helped me, not only medical providers, but also psychologists that they may be working with or social workers that they may be working with. That can be really useful, you know, just getting them their emails to each other. So facilitating that communication, giving, you know, a lot of the times, and not a lot of the times, the people that you want to share information between should have paperwork with release signed, giving your approval to share information, and taking that initiative from the patient's side can make that process a lot smoother. Also, discuss what's the best communication method and expectations in communication. And this one it's particularly important because, you know, for example, electronic medical record messages don't usually go directly to the physician. They usually go through an office that screens them. So it may take 72 hours for the physician to get that notification. So you need to be aware that there's going to be a gap. And if it's a communication that you expect a return in the message in less than 24 hours, or you're conveying something that would qualify as an emergency, for example, that you're having chest pain that gets worse with activity and gets better at rest, and you were getting sweaty, or, you know, things that would raise red flags about needing medical care sooner. It makes it really difficult to receive that message, you know, 5 days later. And as a physician, you just, you know, try to get a hold of the patient as soon as possible. But it is important that you understand that that medium of communication is not for immediate response. And then keep it real. Let your doctor know how you really feel. If the medication is not working, let them know. If you you have any clues that may chime, anything that you're experiencing, we really want to know. We want to know what your experience is. It's going to only help us serve you patients better. So the clarity and the transparency in communication, it's truly important. Next slide. That's it. I hope that this is helpful and open to answer questions. And excited to listen in on the generation of conversation after this.
Thank you so much, Dr. Azola. You covered a lot of information today, and I was looking through the chat, and there's a lot of comments in there and questions in there as well. So I can't wait to get to that part of our session and then get that discussion going.